So what I'm going to talk about is not, partially also what I do in my own practice as family physician, but also what is being recommended by international journals of family medicine. The one I'm referring to is type 2 diabetes mellitus outpatient insulin management. And this paper was published in 2018 in American Family Physician. So if you search this paper, you'll get more or less a practical guidelines to what we should be doing in outpatient management of diabetes with the help of insulins, because often our concepts are not very clear about insulin as such. There's not one type of insulin. There are several types of insulins, and it is important that we know practically how these insulin types work, what they do when we inject insulin in our bodies, because insulin is also been dreaded, as we know that it can cause hypoglycemia, and that is a common situation many times when we manage patients of diabetes. So even patients are aware and they're reluctant to start insulin because they are not adequately educated, or they are not adequately convinced about the outcomes and managing its logistics. It is also a costly affair as compared to oral hypoglycemic agent. So, as physician, we should be knowing when we should start insulin, how much it costs, and in what doses we should initiate, how we should titrate the doses with the objective levels of sugar level or HbA1c levels of our patients. So as we see, the purpose of this slide is to show globally family physicians manage diabetes in primary care setting, and this management protocol is not different from any other discipline, any other kind of physician. We also have to manage insulin in a similar standardized manner. And management of diabetes is not different in family medicine than it is in internal medicine. It is same. And management of most of the diseases is uh, is is it depends on the patients. It does not depend on the provider. We are licensed physicians, so as provider, we should be catering to the needs of the patient, and whenever there is a complication, we should refer to appropriate specialty. And diabetes, as we all know, is a multi-system disease. It impacts whole body because there is a microvascular changes through decades. It's a long-term condition, and there, major end organ damages can damage brain, heart, kidney, liver, uh, extremities, limbs. So, it can cause infections. It leads to immunosuppression, low immune status. So, diabetic patients are vulnerable to many types of, insults, uh, of diseases, infectious, non-infectious. So it has, multi-system uh, outcomes, or involvement. So if you look from that perspective, family physicians, because we take care of all organs, all genders, all ages, uh, we are the best position to provide care for uh, diabetics of all age groups, all stages of life, and all types of diabetes. We should be capable of managing, and we can do that by learning ourselves. How do we how it is, because this is all evidence based, protocol based. Insulin is, we all know, it comes from pancreas, and uh, the two types of uh, cells, alpha and beta. uh, it comes, diabetes originates from beta cell dysfunction, and then uh, the sugar is not carried into the tissue or cell. It remains in blood because insulin helps to transport sugar into the tissue. So these are the main areas where insulin dysfunction affects muscles, liver, and the uh, fat. So this is all a repetition of what we have already discussed earlier: rapid acting, short acting, intermediate acting. ultra long acting, and this is a graph to show how the plasma levels differ, and then the graph of time hours. So a rapid or short bolus would meet its peak early and would last between 4 to 8 or 10 hours,